Welcome, everybody. My name is Larry Hoffheimer. I am the founder and chairman of the Macular Degeneration Association. We are pleased to present a series of webinars focusing on general eye health with a special focus on macular degeneration. We have a series of speakers that present absolutely fantastic, informative presentations about different aspects of treatment and outcomes for macular degeneration. I also want to thank our sponsors, Regeneron Pharmaceuticals, Novartis, and Notovision that you'll hear from later today. Please use the question and answer button at the bottom of your screen to ask your questions, and Dr. Rathod is going to be answering those questions after his presentation. There's also a survey available at the close of the program. Please take it. It's about 3 minutes long, and it helps us better serve you. It's now my pleasure to welcome our speaker, Dr. Rajiv Rathod. He is a member of the Macular Degeneration Association Medical Board, and he's a board-certified ophthalmologist and a native of Orange County, California. He completed his undergraduate education at Stanford University, receiving a BS in biology. He returned to California for a year after completing an internship at Santa Clara Valley Medical Center in San Jose. His residency was completed at Washington University in St. Louis, where he received several awards for teaching and patient care. It's now my distinct pleasure to introduce to you Dr. Rajiv Rathod. Dr. Rathod.
Good evening, everyone. Welcome, and I want to thank Larry and Donna and Andrea and the Macular Degeneration Association for inviting me to give this presentation. I'm just going to pull up my screen here. So I am going to talk about, of course, macular degeneration and the treatments that have evolved over the last few years in terms of what it is we can do for macular degeneration. So before we start talking about treatment for macular degeneration, it helps to review exactly what it is that we are referring to when we say macular degeneration. Well, macular degeneration is a common degenerative disorder, and we don't fully understand exactly why it happens, but typically it's associated with aging, and it affects older individuals. And what it's characterized by is loss of central visual acuity. So it affects the central vision, and it's through a deterioration in the normal cells and function of the retina. The retina is the important organ of the eye that's responsible for turning light into information. So a very important, delicate part of the eye that we'll show you in just a moment. So what is the overall impact of macular degeneration? Why are we even talking about this? Well, it's obviously a common disease. It's the most common cause of irreversible vision loss in Americans over the age of 60. Probably more than 15 million Americans are affected to some degree. There's a new diagnosis of macular degeneration every 3 minutes. So again, you can see how relatively common this disease is. And obviously it can have a significant impact on vision and function and lifestyle because of how it affects individuals. And so a very important consideration in terms of someone's day-to-day life if they have a problem with their vision due to macular degeneration. In reviewing the anatomy of the eye, you can see that when we talk about macular degeneration, it specifically refers to the area of the macula which is highlighted by the small box there. And it's a very, very small region of the retina, and the retina lines the inside back of the eye. So we're talking about an extremely small area of the eye. However, extremely, extremely important, because that's where your central vision and the detail you see comes from, that very little area of the retina. So very important, but also very delicate and very sensitive. So that's what we consider the macula, and that's the area that macular degeneration affects. And so what is the effect on vision if one is to develop different degrees or different stages of macular degeneration? Well, initially there may be just some blurring where things are not perfectly well focused right in the middle. And then as it gets a little more advanced, the images can become even more blurry. Things can become wavy and distorted. Straight lines can become crooked and wavy. So those are the common symptoms. And again, this is right in the central vision, right on what you focus on. It generally does not affect the peripheral vision. So one of the first questions anyone who comes in with a diagnosis of macular degeneration asks is there a cure for macular degeneration? And unfortunately, at this time, the answer is there is no cure for what we refer to as AMD, or age-related macular degeneration. So that's generally the bad news that we have to start with. However, there is some good news, and the good news is that we do have treatment that exists for certain stages of age-related macular degeneration. In addition, this is a very active area of research. A lot of folks, a lot of smart people are putting a lot of time and energy into coming up with potential newer treatments, and ultimately the goal is a cure for macular degeneration. That may be many years away, but it's a very, very active area of research. And in even in the next few years, we could have some newer treatments that can help to slow the disease and or treat the effects of the disease, which we'll talk about. So before we get to where treatment is today and what we might expect to see in the future as far as treatment for macular degeneration, we should certainly talk about the history of macular degeneration. Well, macular degeneration has actually been known about for many, many years. The first descriptions of macular degeneration and the association between a problem in the central retina and vision decline were first documented in the mid-1800s. Over the years, as technology and our ability to examine and evaluate the eye evolved, we started to gather more and more information and specifically identify this cluster of diseases or problems with the central retina, which are called age-related macular degeneration. And then it was further classified into different subtypes as time went on. The first treatments then began as, again, technology advanced, and we understood what the underlying problem was in some types of macular degeneration. Then some of the treatments began in the 1980s. And what did treatment look like for macular degeneration? Well, early on, laser treatment was done for macular degeneration. And in this case, the goal of the laser was to actually burn part of the retina where there were blood vessels growing under the retina. And those blood vessels were what was a causative agent for what we call the wet type of macular degeneration. And so the goal was to stop further leakage or bleeding out of those blood vessels by cauterizing, essentially, with the laser, or burning those blood vessels. The laser also created some additional damage on its own because it's a laser. And so this treatment, although potentially reduced the rate of decline of vision loss, still inevitably led to significant vision loss. So this was not necessarily a great treatment. Then through applications in other parts of the body, some folks found that there was a different type of laser treatment that could be applied to the retina to try to stop those blood vessels from growing and causing fluid and blood to leak into the retina. This other type of laser is what's referred to as a cold laser, and it's called photodynamic therapy. And in this type of treatment, a photosensitive dye is injected into the vein, and as that dye circulates throughout the body and the system, a laser is then applied to the retina directly, and this is not a burning or thermal type of laser, but this laser actually activates the molecules of the dye as it runs through the blood vessels. And in doing so, the goal is to internally block or close off the leakage of the blood vessels by activating that photosensitive dye within the blood vessels. So that's how the treatment known as photodynamic therapy works. And this was the next stage of treatment that actually had some beneficial effects. And what we saw was that we knew that people with wet macular degeneration inevitably were going to continue to have a decline in vision. This sort of slowed the rate of vision loss over time. However, there was still ongoing vision loss due to the wet macular degeneration. But this, in a small percentage of people, did have some benefit. This is, however, still not a perfect treatment and was not sufficient for us to say, hey, this is as good as it gets. So then that leads us to current treatments for macular degeneration. Where do things stand basically today? So let's talk about that. So before we actually talk about specific treatments, I'm going to back up a little bit and talk about, in general, what can one be doing if they're diagnosed with macular degeneration. And that's generally the first thing that folks ask when they're referred with a diagnosis. They say, my optometrist or my ophthalmologist told me I have macular degeneration. They've referred me to the retina specialist. And what is it now that I should be doing to help protect myself, my eyes, going forward? Well, and I tell this quite often to many of our patients. It begins with taking care of the rest of your body. So a healthy diet, taking care of your body, eliminating all the foods and things that we know are not healthy for the body, are generally considered good, and eating a well-balanced diet rich in green leafy vegetables, nutrients, lots of fruits and vegetables that have healthy nutrients that support the health of the body will also actually be beneficial for the eyes. Next, of course, is exercise. And of course, we often find an excuse, not to exercise, but we know that there are many potential long-term benefits, not just to the eyes, but in general for exercise. And when given the option of exercise, sometimes obviously we take the easier route. And we have to remember that every little step we take has some benefits. So exercise is also very important. And the one modifiable risk factor we know of that can potentially make macular degeneration worse is cigarette smoke. And so if you are a smoker or exposed to cigarette smoke, it is very essential to avoid this, because we know that that will make macular degeneration worse. And I also tell people when they're out in the sunlight to protect their eyes from UV light, you should get sunglasses that block UVA and UVB light, and most sunglasses nowadays do. It should say it on the label. But especially if you spend extended amounts of time outdoors, it's very important to wear some type of protection from the harmful rays of light, which are the UVA and UVB light. So then when we get to the specific subtypes of macular degeneration, what are the treatments that we have nowadays? Well, let's start with the dry macular degeneration. And dry macular degeneration is generally the most common type of macular degeneration that people are diagnosed with. That's what most people start with. And dry just means that there's no fluid or bleeding from the blood vessels causing swelling in the retina. And again, 90% of people who have macular degeneration have the dry form of macular degeneration. At this time, there is no treatment or therapy that exists which stops or reverses the progression of dry AMD. So we don't have any good treatment for the dry type of macular degeneration. So what are the recommendations? So if someone comes in with a diagnosis of macular degeneration, what do we tell them? Well, in addition to the lifestyle modifications that we discussed earlier, we specifically recommend a vitamin therapy. There's a specific formula of vitamins called the AREDS2 vitamins, which have specific components of antioxidants and macular pigments, including lutein and zeaxanthin, which in a large study were shown to help protect the eye from progression to a more advanced stage. It's not a cure, it's not a treatment. It's basically to help reduce the chance of progression by about 25% to a more advanced stage of macular degeneration. So that's the recommendation if you start off with dry macular degeneration. Besides that, currently no other medical treatments exist. Now, if you get to the advanced form of the dry macular degeneration, sometimes we refer to this as geographic atrophy. That means that the retina is basically thinned away and broken down so that you're left with a large blind spot right in the middle of your vision. For folks who go down this pathway of macular degeneration and start to develop atrophy of the retina, there's really no way to stop that progression at this time. So if one gets to that point where there's significant vision loss as a result of the advanced dry macular degeneration, generally we recommend an evaluation with a low vision specialist. And the purpose of that is to find tools and aids in day-to-day life that can help to maximize the vision that is still there. So take advantage of the peripheral vision, learn how to use the peripheral vision around the area of atrophy better through magnifiers, loops, telescopes, etc., to be able to use images. Sometimes people can read with image enlargement aids. They have cameras that will you can put over a book that will enlarge the image onto a computer screen. So there's many different tools and aids that a low vision specialist can evaluate for to see what might be beneficial in order for one to be able to continue some of their desired normal day-to-day activities. Also, proper illumination is essential if you have macular degeneration, because your sensitivity to light goes down with the loss of the retinal cells. And so it's important to have very adequate illumination, and most patients will recognize this and realize that they need to be in direct bright light to be able to see some of the things that they used to be able to see in dim light. Besides that, as far as the advanced form of dry macular degeneration, there is one particular surgical treatment that has been approved for this type of advanced macular degeneration, and this is a miniature implantable telescope, and this is placed as a lens implant inside of the eye. This is FDA approved, and that lens implant is placed where the normal lens of the eye is. So if someone is having cataract surgery, the cataract would be removed and this would be placed in its place. And the goal of this type of implantable telescope is to magnify an image so that it falls on a larger part of the retina, again, taking advantage of the part of the retina that still functions properly, so that potentially some images can be seen a little bit better by a patient. So this is approved. I can't say it has taken off, and it has some limited applications, and they are going through, they have gotten a new approval for a newer type of device that can be placed easier into the eye. Some of the difficulty was in performing the surgery itself, but they are looking at a newer device that could make it easier to perform the surgery and potentially benefit more patients. This type of device is generally considered challenging to accommodate to, and requires a fair amount of training in terms of vision exercises and vision training to be able to take advantage of the benefits. So it doesn't apply to everyone. It's a very specific patient and problem in which this potentially may have some benefit. So if it is being considered, it should be done so carefully in conjunction with the retina specialist and low vision specialist. So let's talk about wet macular degeneration. And again, we refer to this as wet because that means there is fluid or blood building up into the retina as a result of blood vessels that are leaking. And so that's why we refer to this as wet macular degeneration. So the current standard of treatment for wet macular degeneration is a type of medication that is injected directly into the eye. We call this an intravitreal injection because the medicine is injected into the vitreous, which is the gel that fills the middle cavity of the eye. And again, this is first-line standard of care treatment for wet type of macular degeneration. This has become the most common medical procedure performed out of any procedure in all of Medicare. So more than any other type of procedure or surgery, this is by far now the most commonly performed procedure. So we have several different medications that have been approved by the FDA for treatment for wet macular degeneration. The first one came about in about 2004, and that was called Macular. And that one did show some benefit. However, within a couple of years, another agent called Lucentis or ranibizumab was approved by the FDA. And this one was actually found to be quite a bit more effective. And so in general, Macular was replaced and not used very much after the first year or two because we had an agent that's worked better. And so then since then, we've had several other medications that have become approved for treatment for wet macular degeneration. Now, these medications are also approved for other conditions, including in certain cases for diabetics and then other types of retinal vascular disease. So you may hear of somebody getting shots in the eye, not necessarily for macular degeneration, but it is certainly approved for more than one condition. So those are the ones that the FDA has approved. Now, there's one agent that you may hear folks talk about quite a bit, and this particular medication is a cousin of one of the other ones that are approved. This medication is called Avastin or bevacizumab, and this is actually approved for treatment for cancer, for several different types of cancer. It was, however, found to be also effective in treating wet macular degeneration, and so some smart person said, let me just take a small amount of this and inject it into the eye, just like we do with the other medications. And they found that it was also beneficial. So this also works for wet macular degeneration. It's not FDA approved. However, it's widely used and generally considered acceptable. And Medicare also accepts this as a valid treatment for macular degeneration. This particular medication, again, is marketed or bottled for use in cancer treatment. And so if we use it in the eye, it must be compounded at the pharmacy. So the pharmacists have to draw up individual vials under very specific sterile conditions. And then those vials are then distributed for treatment for the eye. So very different process from the other ones, which are preset or delivered specifically ready to treat for the eye. So that's sort of where things stand currently in terms of treatment for macular degeneration. And just to give you a little more of a description of what that is like. So when someone comes in for an injection in the eye, it's generally a painless procedure. The eye is numbed up really well. The patient will feel a little pressure sensation, but it's not a painful procedure. Initially, the treatment is about once a month for most patients, and then ultimately the goal is to try to extend that treatment so that it's not necessarily every month, maybe every second month, every third month. Everyone responds somewhat differently, so those are sort of the goals of treatment, is to try to stabilize the condition. Again, the good news is that it works very well for controlling the wet macular degeneration, and often patients who have lost vision already from wet macular degeneration can actually regain some of their vision and maintain that vision over many, many years. I have several patients who have been getting shots for over 10 to 12 years, and they continue to maintain very good, useful, functional vision. They can read, they can watch television, they can drive. Whereas had they not had the injections and the treatment, then inevitably they probably would have lost a lot of central vision and not been able to continue to do those things. So the injections have revolutionized our field and have revolutionized our ability to treat and manage and control a potentially very devastating disease process. So let me now switch to the future of treatment. So we've talked about where we started as far as past treatments, what our current treatment is for the different types of macular degeneration. Now let's talk a little bit about what the future holds. So let's see what's in the pipelines. Let's start with dry AMD. As I mentioned for dry AMD before, we don't really have any particular treatment that we know slows the progression. All we can say is take vitamins and we hope that reduces the chance that it will progress. So we really need or want something that can slow the progression and or treat once a patient develops more of the advanced dry macular degeneration. So there are several companies that have products that are being evaluated for treatment for the dry advanced type of macular degeneration. There's one particular one which has promising results from initial clinical trials. They actually completed their phase 3 trial, and the results are due any time now, actually. And we're hoping that this actually is the first agent that gets approval for treatment of dry macular degeneration. And the goal with this particular molecule, and this is given as an injection into the eye, just as the other treatments, the goal of this molecular treatment is to slow the progression of deterioration or thinning of the retina. It doesn't treat it, it doesn't restore vision, but if we know at an early stage that someone is starting to develop thinning of the retina or atrophy of the retina, and we can start treatment and potentially slow it, then we may be able to maintain their vision at a better level for a longer period of time, and potentially even keep that vision functional during their lifetime. Whereas without the treatment, it would be a more rapid decline, and within their lifetime, they may suffer significant vision loss. So that's the goal with this type of treatment, and we're really hoping that this gets approved later this year. So that would be the first treatment. There was one that was submitted a few years back that we were very excited about, that we thought would potentially get through, but the final data did not show promise or good results, in fact. And so the FDA did not approve that one. And that was about 3 years ago that went through the FDA and did not get approved. So since then, we haven't had anything, but this is the next potential target. There are a few other companies looking at different ways of treating dry macular degeneration, including looking at human stem cells to replace the retinal cells that aren't functioning properly. In this case, the retinal cells are derived from stem cells again, and then injected directly under the retina in the surgical procedure, in hopes to potentially restore some of the lost function. There's another company that's looking at a treatment for an intermediate dry AMD stage, which is again, this is before even the advanced stage, so at an earlier stage, and they have some promising initial results from their clinical trials. We also have another potential player in the field that has shown some very promising initial results for reducing the progression of, again, the dry macular degeneration. Another company that is also pursuing a similar type of molecule that can slow the progression of dry macular degeneration, and another one that's in an earlier phase. So as you can see, this is a very, very active field, and there are many different companies pursuing different treatment options and molecules for treatment of dry macular degeneration. Another one that's of note that I'll talk about here is actually, this is a surgical treatment, and this is called regenerative patch technology. In this case, a stem cell derived patch. It's a patch that actually has a layer of stem cell derived embryonic cells placed on the patch, are surgically implanted underneath the retina. And the idea is that those cells, you can see the size of the patch here, so that patch is actually placed underneath the retina through a surgical procedure. And those cells can, the idea is to hope that those cells will replace some of the lost functional cells of the retina, which have deteriorated over time. So that's still an early phase development, but the procedure has been performed and with some initial promising results. So that will also be pursued in the future. That's a long ways away from being approved, but that is something that could have some clinical applications down the road. So that's for the dry AMD. Now let's talk about wet AMD. So for wet AMD, as you know, we actually have very good treatment, as I described earlier. So we do have injections and molecules that can stop and slow the progression and even improve the condition for wet macular degeneration. So what is it that we need? What is research looking at in order to develop newer agents or newer treatments for wet macular degeneration? Well, right now there's a huge burden on the healthcare system and on patients in getting these treatments, because often you're getting treatments once a month. Sometimes patients have the problem in both eyes, so they're coming in every month to get treatments in both eyes. So that's a lot of office visits. That's a lot of injections in the eye, which again is not generally painful, but is obviously psychologically daunting to many patients in terms of having to get a needle injected into the eye on a regular basis. So are there things that we can identify that potentially work better than what we have, or that last longer than what we have? Or potentially, is there something that's easier to deliver than what we have? And that may be in the form of an eye drop, an oral medication, etc. So there are different ways of delivering medication to the body and to the eye that could potentially have similar effects. So let's talk about this particular molecule called faricimab. So this is from the same company that has Lucentis, which was as I mentioned, one of the first approved injections for wet macular degeneration. They have a molecule that actually completed clinical trials and has submitted as of last month to the FDA for expedited review for potentially approval for treatment for wet macular degeneration. This molecule is novel in that it actually is two different molecules in one. So it targets two different pathways in the underlying problem with wet macular degeneration. And the initial data suggests that patients can do just as well getting shots every 4 months as other patients who are getting them every month or every 2 months. So the idea is that after starting treatments, then you can quickly extend the treatment out to every 4 months, therefore reducing the burden on patients in terms of having to come in as regularly for their injections. And so this molecule potentially has more durability in terms of how long it lasts. So that may be the next thing we see that gets approved, and we're hoping to see the results of the response from the FDA by the end of the year, actually potentially even within the next couple of months. So that's what we're very excited about right now in our field. There's another company that has a similar dual mechanism molecule, which is still in the early stage development, but has sort of a similar approach in terms of targeting two different pathways in wet macular degeneration. There's another company that has a very new type of molecule. It's a different molecule than one that currently exists, and that's a more targeted therapy for wet macular degeneration, specifically targeting what is more potentially the causative problem with wet macular degeneration. And they're early in their trials, but they have some initial promising results. Another company has another type of medication, which also potentially shows longer durability in terms of lasting at least 3 months. And this is ongoing trials for wet macular degeneration, and we're hoping to get more data and results on that. Another type of treatment, and again, we talked about different ways of delivering medication, and in this case, this particular company, REGENERATIVE, has a type of gene therapy, which is actually delivered into the subretinal space, so underneath the retina through a surgical procedure. I would describe the other patch technology. So the same area of the retina delivered a little bit differently, but in this case, this is gene therapy. And so what happens here is that a vector is introduced into the space underneath the retina, and that vector induces the cells of the retina to start producing medication itself. And so basically, instead of having to inject the eye with medication from the outside on a consistent basis, you're creating a factory underneath the retina to make the medication within the eye itself. And then so you have a sustained production of the molecule which helps to control the macular degeneration. And this, again, can lead to extended durability and potentially even improved efficacy in terms of having a more consistent and steady state treatment rather than getting interval treatments, on a monthly basis. So we think this is very exciting technology. The clinical trials for this have just begun and are underway. So that may be something that we see in the future. Another company has another similar type of gene therapy treatment. However, this is just given directly as an injection into the eye, the way we currently give injections into the eye. But this is also gene therapy where the vector tries to induce the cells within the eye to produce the medication from within the eye. So it may have some initial positive results. Some other things we are looking at are drugs we call biosimilars. And these are medications that are very similar in terms of their molecular structure to the existing treatments we have from the FDA-approved drugs. The benefit here is that these may work just as well, but have a significantly reduced cost in terms of the burden on the healthcare system, because the other medications are rather expensive. And so that is a big burden on our whole health system as a whole. And so each of the different molecules that are approved by the FDA has what we call a biosimilar, which is being tested potentially to be approved for use similar to the other ones. Another treatment approach, again, looking at different ways of delivering medication. There's another type of surgical treatment, which we call an implantable drug delivery system. And so this is a device, and this is also by that same company, as I mentioned, Genentech, that has one of the early approved medications, and then the other molecule that's potentially going to be approved later this year. But they've also come up with a surgical implant. And basically, this little implant is placed into the eye, it's secured on the wall of the eye, and allowed to deliver medication through a reservoir at a steady state into the eye directly. And so again, this is placed surgically, and it's only visible if you look for it very carefully, but it's basically covered by the skin of the eye and the upper eyelid, so that if you were looking at someone who has it, you wouldn't be able to tell that they have it. And the patient themselves can't see anything in the eye when they're looking out, because it's in an area that's that doesn't have any sort of reflection on the vision. So this is a very discrete device, and as I mentioned, it acts as a reservoir to hold medication and slowly deliver that medication over an extended period of time. The medication within that reservoir can also be refilled once the effect has faded or worn off. The medication can be refilled with a simple needle in the office, much the way injections are currently given. The benefit here, again, is that you get a constant, steady state delivery of the medication to keep the disease under control, and this can potentially last longer, even potentially 6 months or a year. So this is another exciting area of treatment, and this has a lot of initial very, very promising results. they're well into the last phase of clinical trials. And so as more data is gathered, this will ultimately get approved, submitted for approval from the FDA also. And we're excited that this may be part of the future of treatment for macular degeneration. So again, just very different novel ways of treatment, of delivering medication in order to best control the disease activity of wet macular degeneration. So that's sort of what the future holds in terms of our macular degeneration treatment coming up in the future. At this time, I will stop my presentation and address any questions that arise. So first question, how do I know if I need a low vision doctor? My doctor hasn't said anything to me. I am having trouble reading and seeing faces. So generally, a low vision recommendation is given if someone is still having trouble with their vision despite getting new updated glasses, having all other medical conditions of the eye treated and looked at. And generally, this is based on the guidance of your optometrist or ophthalmologist. Generally, your ophthalmologist, and specifically if you have a retina specialist, they can help you determine when it's time to see a low vision specialist. And that's generally when you've reached a somewhat more advanced stage that we generally recommend low vision specialists. And because those are some more specific types of tools and devices that they would evaluate. The next question, I heard that the implantable telescope is hard to use, and then why is that? So yes, as I said in my talk, the telescope requires a fair amount of training and vision therapy. You have to essentially train your brain to see in a different way than you're used to seeing. And so that that can be very difficult, and that it takes a lot of time and effort and motivation, in fact, on the patient's part, to be able to retrain the brain to use it differently, because you're not using the vision the way you're used to. One eye has to see a magnified projected image for as best the central vision as possible, whereas the other eye is used for peripheral vision and navigating around the room, for example. So you have to kind of use the eyes differently and train the brain to use them differently. So that's why it's hard to use. Next question, I've received conflicting recommendations around using a blue screen monitor or film over my computer screen and smartphone. Does darkening electronics or having a protective screen help prevent blue light from harming eyes? So we don't have direct evidence that blue light is actually harmful over time to the eyes. Many people think it is, many people think it isn't. So there is conflicting information. There's not a absolute answer to that. If one is concerned about blue light emission from screens and computer screens and smartphones, etc., then certainly you can use a protective cover over the monitor or the screen, or wear glasses that have a blue light filter. Now, a lot of people don't like this, especially if they have eye disease, because it reduces the amount of light that gets into the eye and can affect the quality of the vision. But if you're concerned that there could be damage from that, and again, we don't have a clear answer, and the answer is probably no, but you can certainly use one of those things to reduce the blue light that comes from it. Just dimming or darkening the screen, there's still blue light that comes from those monitors, so that doesn't eliminate it completely. Next question, do you think there will be a treatment for dry macular degeneration soon? We certainly hope so, and as I said in my talk, we're potentially very close to getting the first agent that can treat dry macular degeneration. My eyelids get swollen and turn red after getting the eye injection. Is there anything that can be done to stop that? So sometimes that can even be a reaction to some of the things that are used to prepare the eye for the injection, including the antiseptics and the anesthetics that are used to numb the eye and help prevent infection. Having the eye rinsed really well afterwards generally helps. Some people like to get an antibiotic ointment placed in the eye afterwards that helps with comfort, and that can help with the swelling. Sometimes putting a patch over the eye afterwards can be helpful. So there are different ways to help to reduce that if that happens consistently every time. And you can go over those different options with your doctor. When I get the injection, it hurts. What can I do? Well, there's different ways to numb the eye or use anesthetic in order to reduce pain with the injection. So that is something that you can discuss with the doctor that gives you the treatment. But again, there's different levels of anesthetic and numbing that can be done to reduce any pain or discomfort with the procedure. We generally use several rounds of drops and numbing swabs that have anesthetic soaked on them to numb up the eye. And our process for numbing takes anywhere from 15 to 20 minutes. So we spend a fair amount of time on the numbing process so that the injection itself, for the most part, doesn't hurt. There still may be some pressure, but it doesn't hurt. There isn't a way of doing an even deeper numbing medication where you actually inject anesthetic under the skin of the eye at the site of the injection. So again, there are different ways of potentially reducing pain and discomfort from the injection, which you can discuss with your doctor. Next question. I heard that there is an implant coming out that will hold 6 months of medication and will release as needed. Is this true? And when will this be out? So I described that in my talk as the implantable reservoir. So that's called the port delivery system. And so that's still going through clinical trials. And we don't know exactly when that will be available, but we're hoping within a couple of years. But it has, like I said, initial very promising results. And I showed images of that in my talk also. Next question, is surgical scleral buckling to control retinal thinning in myopic macular degeneration a newer or older treatment? So we're talking now about a very different condition. This is myopic macular degeneration, which occurs as a result of being extremely nearsighted. And what happens in this case is that an extremely nearsighted eye is very large and very long, and the back of the eye, the wall of the eye is very thin, and that can become very thin and lead to pouching out of the retina at the back of the eye. And so sometimes what we call a scleral buckle is placed surgically to help bolster or support that part of the wall of the eye and the retina in the very back. That has been around for some time. And it is a treatment option for very advanced severe cases of myopic macular degeneration. But that has been done for some time. It's done much more frequently in some of the other countries where there is a lot more very, very high myopia or high nearsightedness, such as some of the Asian countries. But that treatment has been around for some time. Next question, will gene therapy be a cure for macular degeneration? So depends on what you're defining as cure. So if you mean curing the disease altogether, that is unlikely to be a total cure. Could it treat the effects of the disease? Yes, that's what we're hoping for. But it's not going to necessarily be a cure for the disease itself. So that may be a long, long time away, actually finding a cure for cure meaning preventing the disease from actually happening to begin with. The gene therapy at this point is just being used as treating the effects of the disease. Next question, do you have any information or review of the device I believe is called ORCam that monitors dry AMD? Is this useful? I don't have any information on that, so I am not specifically familiar with that particular device. Next question, any wet macular degeneration, wet macular treatments coming up in the near future? I went through that in detail in my talk, so I won't answer that question again here. Next question, are there preservatives in any of the medicines used to treat wet AMD? So the injections, intravitreal injections, when they're injected into the eyes, those medications themselves do not have any preservatives because those could potentially be toxic to the inside of the eye. So those do not have any preservatives. So I believe that is all the questions we have.
Thank you everyone for attending tonight's webinar. This concludes our presentation for today. Thank you and have a great evening.